2001, there had been 3 phase 1 trials in the United States and several in Europe. Then the phase 2 is where we are now. Phase 2 means still small trials giving the drug to humans, but to test treatment effects and safety in people with a given problem, diagnosis. So all the trials that we're doing now with MDMA for PTSD are phase 2 trials. Those are working toward eventual phase 3 trials, which are similar kind of design, but much larger, and have to, almost always occur in multiple sites to get enough people, several hundred people. You need 2 of those to get a drug, apply for a drug to be approved. So we're in phase 2 right now. We've already said that stuff. And we didn't actually do the first phase 2 trial. The first one was started in Spain. Marcela Otlora was one of the co-therapists. Jose Carlos Busso was the other one. And they unfortunately got shut down after only a few subjects and before they got the full dose, but they showed safety. So ours was the second one to start, the first one to finish. The first one that we started in 2004 and completed in 2008, published last summer in the Journal of Psychopharmacology. Yeah, there wasn't any safety problem. The study in Spain was shut down for political reasons. Yeah. There wasn't a scientific or medical reason for doing that. So what's happening now is another phase 2 trial has been finished in Switzerland. Peter Owen and his wife Verena, and they're going to be publishing that soon.
They did 12 subjects.
Mm-hmm. Right now, we're doing 3 studies in Charleston. The main one is PTSD, for veterans with PTSD. And we're just enrolling our 6th and 7th veteran in that study. We're also doing the study Rick mentioned, in which we have permission to give MDMA to therapists who have been through the training program and are going to work on research trials. And we also just got approval for a relapse study, because we've had, out of the original 20 people in the first trial, although the benefits lasted for most people, we know 3 people who have relapsed. So we have permission to give them one more MDMA session to see if somebody who responded well at first but then relapsed several years later will benefit from an additional study, additional session. Nearing approval, about to start, is a study in Vancouver. Ingrid Percy is the principal investigator who's sitting here. And also the study is nearing approval in Israel, and one in Jordan that we thought was nearing approval, but it's been kind of delayed, so we're not sure when that'll start. And there are protocols in development in Colorado. Marcella is doing, going to be doing one in Colorado, and also in Australia and England there's protocol development. So there's a lot happening right now. It's picking up speed. Any questions or comments about that? Yeah.
What about Russia?
Well, Rick knows more about that.
I'd say Russia is, you can't get permission to do research with Schedule I drugs in Russia. So there was incredible work in the 90s with ketamine for the treatment of opiate addiction and the treatment of alcoholism in Russia. And then once ketamine started becoming a recreational drug in Russia, they stopped all the research with it, even in the treatment of drug abuse. So it's just a very heavy-handed system there, and so there's no possibility. We were there last summer in Moscow for a transpersonal conference and met with some of the authorities there, and they just told us there's no way in the foreseeable future to do anything there.
Yeah.
Just a question, maybe you'll get to this, but can you give us a sense of the flavor for PTSD and the interaction or the intervention with MDMA? And because we're talking about a relapse study, so how are people walking through and where do they end up and what kind of experiences relapse and how frequently? I'm just kind of curious about it.
Yeah,
How effective is it?
we'll definitely get into all of that, and if you want more detail when we do, please let me know. Yeah.
Who is the researcher?
In where?
Israel?
Israel, it's Moshe Kotler is the principal investigator. He's the head of psychiatry at Tel Aviv University and former chief psychiatrist for the Israeli Defense Force.
And there'll be 3 teams of therapists. We do have a handheld mic too, if anybody needs that for questions.
Yeah.
How is U.S. scheduling applied in other countries? Is it universal, or just because a drug is scheduled as one here, are there other countries that would still allow research?
No. I mean, Rick knows more of the details, but when we even got our first permission from FDA and we're waiting for DEA approval, we, for instance, met with the Israeli Anti-Drug Authority about the idea of research, and Rick was talking to other countries, and no country was willing to even give permission for the research until the U.S. had given full permission. They were very wary of crossing the United States on drug policy. Yeah.
Has the MDMA training for therapists actually started at this point? Or?
Yes, it has. It's very limited right now because there are still a small number of studies going on. But right now we are we have started those sessions for people who are already working in these phase 2 trials now that are about to start and who have been through our training program. That will pick up more when we, it's largely in preparation for phase 3 as well as, some sessions for these phase 2 trials. Okay. So PTSD. I'm sure many of you are very familiar with this, but just to give you a brief overview of PTSD, it's something that happens to people who have experienced a trauma. For instance, the most common kind of thing being rape, childhood sexual abuse. Those were the main traumas in our first study, or war, other assault, accidents, those kinds of things. And everybody has reactions to that in the short term. But PTSD is when people don't resolve those. And the 3 symptom clusters that define PTSD. One is re-experiencing symptoms, which means flashbacks, intrusive memories, nightmares. Another group is hyperarousal symptoms. I'm not going in the same order as the slide, but hyperarousal symptoms like anxiety, sleep disturbance, increased startle response, hypervigilance. And then there are avoidance symptoms, which can be avoiding people or places that remind one of the trauma or that trigger a physiological response. Or it can be inner avoidance, which is very common, emotional numbing, so people are cut off from their emotions. And most people with PTSD have some degree of dissociation, meaning either periods of lost time or spacing out and that kind of thing. This is a really serious problem. In the United States, the lifetime prevalence is about 8%, but it's getting worse. With all the soldiers coming back from Iraq and Afghanistan, probably at least 18% of those have PTSD. I think maybe more. The VA just recently published that 211,000 Iraq and Afghanistan vets have sought treatment for PTSD now, and they're getting 10,000 a month.
No, 3 months.
10,000 every 3 months. It's very expensive, of course, on top of the human suffering. And in countries where there's endemic conflict, and the rates can be even much higher. So it's a big problem worldwide. It's typically a chronic illness with very high rates of comorbidity, other psychiatric diagnoses go with it. Usually people have an average of 2.3 diagnoses. And a lot of disability, suffering, and suicide. And I just read the VA says one vet from Iraq and Afghanistan is committing suicide every 80 minutes right now. So, and in the VA's own study in the San Francisco VA last year, they found that less than 10% of veterans that they identified as having PTSD were getting adequate treatment. So it's very disturbing.
Sometimes it's 6 weeks before they can get an appointment.
And then they might not be able to be seen for, more than once a month. So it's not good. There are clearly recognized treatments that can help people with PTSD. These are the 3 approved, recognized by the American Psychiatric Association: cognitive behavioral therapy, especially prolonged exposure, and cognitive processing therapy, EMDR, psychodynamic therapy, and then, of course, there's pharmacotherapy. The only 2 drugs approved for PTSD are sertraline and paroxetine, Zoloft and Paxil. But a lot of other drugs are used, and almost every veteran we've seen has been on one of those, plus clonazepam, plus quetiapine, Seroquel. And there was just a study from the Yale VA of risperidol, which is similar to Seroquel, showing no effect compared to placebo for PTSD. Yet everyone's getting these drugs because they can't sleep, they're really anxious, the VA is overwhelmed, and they're doing the best they know how, but it's a big problem. So
the Seroquel numbs out all the emotions, like a zombie.
Yeah, a lot of the vets use that term. They feel kind of like a zombie, that you've just been drugged. But it's not really getting at the problem at all. And even in clinical trials that specialize in PTSD, like with exposure therapy, usually there are high dropout rates, and at least, depending on which studies you believe, at least 25 to 50% of people don't respond, even in those specialized clinics, to the existing treatment. So that, even not looking at the vets, that's 2 to 4 million people in the U.S. per year. So it's really clear that we need more choices and better treatments. There are other interesting psychotherapy models that can be useful, internal family systems, COMI, sensory motor therapies. We don't want to imply that there aren't other ways to treat PTSD, but what is clear is that we need more choices and more powerful treatments. There are other technologies for helping people, like catalyzing the therapeutic process. Holotropic breathwork is one. There's some really interesting studies with virtual reality for PTSD. Cycloserine is a drug that is being studied. It doesn't have any perceived effects, but it may make therapy more effective. And then there are other studies using beta blockers and morphine. So there is this idea out there that maybe there's a way the drug can catalyze the psychotherapy. And MDMA is one of those, but it does it in a much different way from the others. But one thing that we really notice is that basically probably most of you here are already kind of have an interest in this. Doesn't seem so strange, but if you're talking to other therapists that think this is like so far out and so different from other therapies, it's useful to point out that while some things about it are much different, other therapies don't spend 8 or 10 hours with someone, but there is a lot of overlap in what happens. You can recognize elements of other therapy in the MDMA sessions. It's a catalyst. It's not it's not an entirely different experience that wouldn't make sense to a therapist that was trained in other ways. although many of them think that it wouldn't make sense. If they really know about it, they find it does make some sense. Any thoughts or questions about PTSD? Other treatments? Yeah.
The differential diagnosis for PTSD, obviously if you have all the symptom cluster, you have it. Do you, for your studies, for example, require every one of those, and do you require other conditions to be ruled out?
Yeah, we have the diagnosis is done by a psychologist who's not part of the treatment team, an independent rater who does a SCID, structured clinical interview for diagnosis, to identify all the psychiatric diagnoses. So they have to be diagnosed by him or her. We have two people. And there are some exclusionary diagnoses. They can't have psychosis, any psychotic diagnosis, bipolar type 1, active substance abuse, borderline personality disorder, or eating disorder with active purging, or DID, dissociative identity disorder. They can have dissociation, but not full dissociative identity disorder, so we rule those people out.
CAPS. And then CAPS.
Yeah, and we do he does the CAPS, Commission Administered PTSD scale, and the score has to be 50 or above, so at least moderately severe PTSD or above. Yeah.
Yeah, this might be a question for later, but I'm particularly interested in the criteria of the substance abuse because there's such a high comorbidity between substance abuse and PTSD. I was wondering, maybe you'll say something about this later on, but whether you will eventually open that up and see if you can treat both concurrently, or because I know right now it's a risk for the research.
Right, that would be interesting. I mean, many people have a history of substance abuse. As you say, there's a very high comorbidity rate. They have to be clean and sober for 60 days to be in the study. I think, yeah, the idea of doing it concurrently makes a lot of sense. Actually, there's a study at the Charleston VA right now using prolonged exposure concurrently with substance abuse treatment, because the usual model is got to get clean first, and that's problematic if they're drinking because they have PTSD. So I see what you're saying. I don't think we can get to that at this point of the research, but it's a good point. Yeah?
You listed virtual reality as one of the treatments for PTSD. I'm not sure, I don't understand what you mean by that.
Well, there's some interesting studies of some in Los Angeles and some in Atlanta, and probably elsewhere, in which they write these virtual reality computer programs, for instance, to simulate driving down a road in Baghdad, and people have a helmet with a virtual reality setup, and so it's exposure therapy. It's kind of like between imaginal exposure and in vivo exposure, and so it seems to have advantages because they can control the level of exposure very easily with that program. So it's pretty interesting. Yeah.
There was a conference. These are funded by the Department of Defense, these studies for virtual reality. And there was a conference that Michael and I were at in Israel with some of the people that developed it. And there was one woman that was at the FOA who was developed prolonged exposure. And so she was saying that MDMA was kind of a drastic approach, but that we should explore virtual reality. And I went to the people who were developing virtual reality, and they said, if you have MDMA, you don't need virtual reality. It's a softer way to bring people into the experience, but it's so locked in them that if you make them feel safe, it'll come up anyway. You don't need to do that.
And that is pretty consistent with what we see. Yeah. But both are ideas of, is there a technology to catalyze therapy? I think it's a great thing to explore. Yeah.
What percentage of these vets also had depression, and did they experience any effects from the treatment for depression?
Yeah, the rate of depression is quite high. I don't remember what the percentage is now, but many of the vets do have depression, meet criteria for depression. and we do the Beck Depression Inventory as one of our measures before and after. So MDMA, you know, I'm not a chemist, but I'm told this looks a little bit like methamphetamine and a little bit like mescaline, which kind of makes sense to me. And it was patented by Merck, as I said. And you know, the terminology is definitely not really worked out. It's often referred to as a psychedelic, but
chemical effects of the body, like raised levels of the aforementioned glucose after drugs were
after what stress hormone?
like several days after it's cleared from the system.
Elsa, would you comment on that? Maybe, can you hand Elsa the microphone? Elsa is the expert on all studies about MDMA.
Understanding you correctly, I don't think there have been any studies that have looked immediately before and after receiving MDMA. No, not prolactin nor oxytocin. That would be an interesting question. Those things have all been looked at acutely, cortisol and oxytocin and prolactin, and not a couple days afterwards.
How about imaging studies, independent of the neurotransmitters? Have people shown any changes in brain imaging long-term after chronic use?
Well, there's a whole slew of studies looking at repeated ecstasy users, but that's really different from MDMA because we don't know whether people have been taking MDMA, and many people take a number of other substances. So often you're dealing with a polydrug using population, and there have been a lot of studies where you might see changes in the serotonin transporter, for instance. But that's really different from the therapy situation, where people are receiving it about 3 times, say. And it is definitely MDMA.
Thanks, Elsa. And it does cause increased activation of the sympathetic nervous system, so there's increased heart rate, blood pressure, and pulse. That's why we screen people carefully for underlying heart disease or cerebrovascular disease. And body temperature may go up a little, pupils dilate. No subject in any clinical trial of MDMA has ever required any intervention for these changes, and they always return to baseline spontaneously as the MDMA wears off. So it could be a potential problem for somebody with an underlying problem, but we haven't seen any problems with the blood pressure or pulse or temperature. There's a small decrease in the immune system, apparently like having about like having 2 or 3 drinks for several days. We haven't seen any problems from that. We have had a couple people get upper respiratory infections or urinary tract infections a day or 2 after MDMA session, so it could be that played a role, but it hasn't been a serious problem. And then, you know, there's always the question of toxicity, and it's a big topic that Elsa could talk all day about. But basically, just briefly thinking in terms of acute toxicity versus possible long-term toxicity in recreational settings versus medical settings. There certainly is possibility for acute toxicity. People have died from hypothermia, heat stroke, dehydration. A few people have also died from overhydration and brain swelling, brain edema, because with the vasopressin effect, the MDMA slows down the clearance of water from the body, and some people have drunk a lot of water to try to avoid dehydration. So it can, you know, it's not without serious acute toxicity, but it's quite rare. You know, you think of the millions of people using ecstasy of unknown potency or purity, and sometimes people take a lot of it. And still, the majority of emergency department visits from ecstasy are actually psychological side effects, anxiety, panic attacks. And no serious toxicity has occurred in any medical settings. In any phase 1 or phase 2 trials, there have been no serious drug-related adverse events. And that is a little over 500 people now who received it in phase 1 or phase 2 trials. So it's not without risk, but used in this controlled setting, so far the risk seems to be low. Long-term toxicity, there's still some controversy about this. Animal studies have shown definitely serotonin changes with high doses of MDMA, and then there are a lot of recreational studies which are very difficult to interpret because they're retrospective and you don't know what people have been taking it off, and people have been taking lots of other things. There was one prospective study in the Netherlands, but the rest are retrospective. And some people think that these show some clinically subtle neurocognitive changes. Although the best one, done by John Halpern, published in Addiction last year, had a pure sample, a relatively pure sample of people using nothing but MDMA, and he did not find much in the way of effects. So there's still some controversy about maybe if you take enough of it often enough, it does have some neurocognitive effects. But from our point of view, what matters in our considerations is what really the phase 1 data about using known doses in this setting, and that is not shown. We did neuropsychological testing before and after MDMA or placebo. In the first study, it had no effect, and there are studies of serotonin transporters have not shown any decrease. So the data in controlled settings is reassuring. It's all about risk-benefit ratio. It's not without risk. Nothing we do in medicine is without risk. But at this point, it appears that the risk-benefit ratio for MDMA used as a catalyst for therapy is favorable. One of the things the FDA brought up in our first conference call with them in 2001 was maybe we should only give it to people who have taken it before because they didn't want us to be creating MDMA addicts. But luckily, we talked them out of that idea, and we haven't created MDMA addicts. So it certainly has some abuse potential, but it's like more than in animal and human people that study this kind of thing. It's maybe higher than hallucinogen, psilocybin or LSD, but lower than stimulants. So it's not, that hasn't shown to be a big problem. Actually, we've looked at this in the Swiss sample. In Switzerland, there was a 5-year period when they had permission to use MDMA, and even though they didn't do any controlled studies, they collected some information, and afterwards, when they surveyed 74 people who had, I think, gotten MDMA an average of 6 times in a therapeutic setting, none of them had used MDMA outside of that. In our first study, we sent people a questionnaire a year or more later, and only 1 out of 21 had taken MDMA outside a therapeutic setting after the study, and she said she'd never do it again. She was trying to recreate the therapeutic setting with a friend, and she said it didn't work out. So, it's not impossible that someone would go on and use it, but we don't seem to be creating MDMA addicts. And most people have told us, actually, people have said, we're concerned, we think this should be available to people who have been in our studies. Have said, we think this should be available to other people, but we're concerned that it needs to be used in this kind of setting. but people that know how to give the right support were a little concerned that any psychiatrist might start giving people this. So they actually tended to sound a cautionary note from their experience and really kind of get the idea that this should be used in an intentional way in a safe setting. So in a way, it's possible that the experiencing in therapy kind of inoculated them from using it other ways. I don't know.
I also wanted to tell you that the Swiss phase 2 trial that was recently completed, sponsored by MAPS, also found that so subjects who completed the Swiss trial, there were 12 subjects, and none of them tried to use MDMA in a recreational setting after participating in the Swiss clinical trial. And also, this was assessed by drug testing specific to MDMA in addition to asking them. So it's a little bit more concrete evidence than self-report.
Thanks, Barry. So, you know, the subjective effects appear usually in 30 to 60 minutes, although we've had some people that didn't really feel much till a little later, and peaks around 1 to 2 hours, and then by about 6 hours, most of the effect is worn off. People have some heightened senses, you know, colors can look brighter, some visual changes, but not true hallucinations. And they definitely have altered time perception and maybe some change meaning and significance of their perceptions. So, despite the name ecstasy, you know, what we see is it can definitely bring up feelings of well-being and bliss. And I think everyone in our studies has had periods of definite well-being and sometimes really blissful feelings. But it also can open up a lot of anxiety and painful emotions. You know, that's been a big part of it too. I think that can be true for anyone personally, but in people with severe PTSD, that's a big part of it. It's not just a blissful experience. And so this is, in the matter of self-control, this is a quote, I can't remember if it's from George Greer's study, but it's from the literature. There's little alteration in the sense of self or control over the experience. I think that's true in many ways, like compared to LSD, for instance. But in people with PTSD, it may not be so true. You know, we've had people that have really had a lot of fear in the sense that they were losing control. You know, maybe because they're so struggling so much for control already that a sense of their consciousness shifting can really scare them.
And also the little alteration in the sense of self, I think in PTSD is also, we've seen that people have had a lot of work about who they really are because they've had these traumatic experiences sometimes from childhood that come up, and there is quite a bit of like working on their self in the sessions, and so I wouldn't say that I would say that that's quite a bit of the work.
And the you know, increased self-confidence and extroversion, that can definitely be true, but also maybe especially in people with PTSD, it may be more increased inner focus and processing emotions inwardly rather than being extroverted. And it does seem to help with interpersonal trust and in the Therapeutic Alliance. We think that's a big part of it, but in people with chronic PTSD, it doesn't mean that's easy, even with the MDMA. That can be one of the challenges of the work, is building that Therapeutic Alliance. But the MDMA definitely seems to help with that. And so, you know, one of the really useful things is it may reduce anxiety without depressing the sensorium, you know, as opposed to benzodiazepines, which you can get rid of the anxiety if you give enough of those, but then people are asleep. And so it doesn't, it can decrease anxiety in people, doesn't interfere with the capacity to experience and reflect upon and communicate about what's going on. That's the beauty of it. But, having said that, it may definitely increase anxiety, sometimes transiently when it's coming on. Some people get really anxious, that sense of losing control. Or later, when painful emotions are coming up, a lot of anxiety can come with it, or in the integration sessions afterwards. So we're going to talk much more about that. And it does, it often does cause like innovative shifts in thinking and new perspectives about past experience, which people with PTSD often have distorted viewpoint, and so it can shift it in a positive way, which is actually more realistic than the worldview they've been walking around with because of their trauma. So it magnifies whatever's there is one good way to think about it, and that can be affirming and joyful or difficult and painful.
And it will bring up whatever they need to look at, which, as Stan always talks about that with breath work, that when you sign up for a breath work workshop, the process starts then, and to look at everything that comes up as part of your process, including the workshop. But we found out with the studies.
3 people in the first study said these exact words: "I don't know why they call this ecstasy." They all felt really glad that they did it and found it was very useful, but it just kind of emphasizes the point that, especially for people with PTSD, it's not just blissing out and then everything's fine. It can be hard, painful processing. So, we're going to take a break in a minute, but this is just a chart of the side effects that we saw in the first study. And it's confusing, so don't worry about all of it. But what I've done is the first 2 columns are MDMA session the day of the session and placebo sessions the day of the session, because the placebo people had the same all-day therapy sessions with the same set and setting as the MDMA people. And then we tracked the side effects for 7, here it shows the 7 days after the MDMA and 7 days after the placebo. So the yellow ones are where it was like clinically significant difference, where there was more in the placebo group, and the blue ones are where it was like clinically significantly more in the MDMA group. So you can see that actually during this session, there were a high percentage had anxiety, but actually quite a bit higher in the placebo group than the MDMA group during the session. But then in the week following, it was higher in the MDMA group. People would have waves of anxiety coming up the week afterwards more often than the placebo people. Decreased concentration was more in the MDMA group both times. Dizziness was more. Drowsiness the day of the MDMA was higher in the placebo group. It's not too surprising. People usually didn't sleep well the night before because they were anxious, but we'd always say, well, one thing, if you get the MDMA, you're not going to be tired. Dry mouth, feeling cold, headache were more common during the MDMA session. Interestingly, insomnia was higher both during that day and the week following in the placebo group. People with PTSD usually have a lot of sleep disturbance. So actually the MDMA, although it can cause insomnia, it was actually helped with sleep, and they slept better than the placebo people. People with placebo were more irritable the day of, and people with MDMA were more irritable the week after. More loss of appetite with MDMA. This is an interesting one because you hear about, the Tuesday blues or whatever, people being depressed. a couple days after MDMA. What we saw was low mood was more common the week afterwards in people who had gotten placebo than people who got MDMA, so we did not see any of that effect in this study. Good, it's good quality MDMA. Nausea, paresthesias, tingling in the arms and things, perspiration, restlessness, ruminations, all more common in the MDMA group the day of. People with placebo had more pain the day of the session. One of the things about people with PTSD is they often have chronic pain. A number of the vets have had, injuries that were causing chronic pain, and sometimes during the MDMA session they'd have a period of feeling comfortable for the first time in years. So it's a good pain reliever acutely. Only 4% had pain during the session. And weakness and visual disturbance were more common in the MDMA group. So it kind of gives you an idea. Yeah.
Okay, just to make a little sense of the data, if you could go back to this, try not to get feedback. The side effects, actually the one with the anxiety is what I'm interested in. Yeah. So MDMA after 7 days, and you have 13, that's 54%. So this is from the phase 2 study?
Yes, I see. The N you're talking about
yes.
is confusing?
Yeah.
It is confusing. The reason 60% of people got randomized to MDMA, 40% got randomized to placebo. This is the data from the first 2 sessions, because there were only 2 placebo sessions. So there were 24 MDMA sessions and 16 placebo sessions that we're looking at. So we didn't count it, how many people had it, but how many times did it occur in a person, for each session. That's why the N is that way. It is kind of strange.
The reason why I ask is because it would be interesting to look at the data and see whether the things that came up during the sessions were sort of predictive of whether there was anxiety later or not.
That would be very interesting. If you'd like something to publish, we'll be happy to share the data with you. You can listen to all the sessions. No, that would be very interesting. One of the things is we're focused mostly on the data we need for the FDA. And there are all kinds of fascinating process measures and ways to analyze the data that we haven't had time to do. And some people we're collaborating with some people to start to do some of that, but we really welcome anyone who's interested in, analyzing these sessions and making those kinds of correlations. We'd be happy to share the information with anyone who's serious about that. Yes, Amy, hi.
Did I miss if you said that all of these reactions ended by day 7? It doesn't mean they had it for 7 days. It just means that they had it on any one of 7 days after the session.
Right, within those 7 days.
Do we have any reactions that lasted past 7 days?
We do, and we don't have that data here. But yes, sometimes these were expected side effects, so we tracked them for 7 days, and then usually they ended within those 7 days. If they continued afterwards, then we tracked them as an adverse event. So some people did have anxiety that went on further, and then we tracked that, but I just don't have that data. Thanks for making that point. Okay, this is the blood pressure. I'm not going to, Barrett's going to talk in detail about this on Sunday. All I'm going to say is blood pressure, pulse, and temperature all went up. They went up more for the MDMA people, but sometimes with the placebo people, they still went quite high during emotional processing, and they all came back to normal. and Vera will give you the details. Okay, maybe we need to take a break. Yeah. I think it's, any more questions or comments about that part, and then we'll come back to this when we come back in 15 minutes.